There was a bar set as low as 40 years old when this was a brand new technology. And then it was 55, and then it was 60, 65. And now there's no official upper age cutoff for who is too old chronologically to receive an allogeneic transplant.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Sarah Wall. Sarah treats patients with blood cancers, such as leukemia. One of the most advanced treatments for these patients is blood and bone marrow transplants, called BMTs. BMTs were a big breakthrough in treating blood cancers and have been around for a while, but initially BMTs were used to treat younger patients primarily. Sarah specializes in using BMTs to treat older cancer patients, and she and the James are leading the way in this field and are extending lives and improving the quality of lives for patients in Central Ohio and well beyond. Sarah, welcome to the podcast.
Thank you. It's great to be here.
Yeah, I'm excited to learn about your work with older patients, especially now as I'm getting a little older, and that's become an increased priority across the board, which is great. But first, I think it would be helpful if you gave people a quick overview on BMTs.
Mm-hmm. So bone marrow transplant, and the B has historically stood for bone marrow transplant, although more frequently we actually get the cells from the peripheral blood collection, so they're stem cells. We tend to use the words interchangeably, bone marrow transplant, stem cell transplant, and we do mean the same thing when you hear us using those interchangeably. But there are two main types, which is autologous, where you get your own stem cells back, and allogeneic, which is where the stem cells come from a donor who's not you. And so the primary deciding factor for those two types of transplants is what kind of blood cancer you have. The autologous transplants are more commonly used for patients with lymphoma or with multiple myeloma. And then the allogeneic transplants are more commonly used for patients who have acute leukemias, myelodysplastic syndromes, myeloproliferative neoplasms, and much more rarely in adults, but also aplastic anemia or bone marrow failure syndromes.
Wow, what is the differences in the cancers that make one better for your own cells and one better for donor cells?
A little bit of that is trial and error, understanding which diseases respond the best to chemotherapy. So with lymphoma and multiple myeloma, the idea with a transplant is that you're going to give a really large dose of chemotherapy, and so giving back your own stem cells is what rescues you from the toxicity of that really big dose of chemotherapy. And so then with allogeneic transplants, the actual principle of the transplant is not to give a massive dose of chemotherapy, but it's to get what we call graft versus leukemia effect. And so when
Instead
we put
of graft versus host.
Right. And so those often go hand in hand, unfortunately. But graft versus leukemia is actually the curative potential of allogeneic transplant, where we're putting in a healthy immune system from another donor, and that immune system is going to recognize those cancer cells and eliminate them, where the host, the patient's original immune system, has been outsmarted in some way by their cancer.
Okay. And when you say it's been by trial, that's clinical trials over the years have established it, and you now know.
Yes. When
you see a patient, you know based on the genetics of their cancer, you know what to do.
Exactly.
Okay. And I did read in your bio that you specialize in allogeneic transplants, and which you sort of explained the difference, but this is fascinating to me that the James is so big and has so many specialists that you can specialize in one. How did that come to be? So
some of it is about, what kind of patients you see in the hospital and what you manage acutely.
Oh, the types of cancer you see would lead to allogeneic.
So disease specialty. And then also the complications are very different for autologous versus allogeneic, When you get an autologous transplant, you're getting your own cells back, so there's not that concern of a mismatch or fighting with an immune system and the host.
The graft versus host disease.
Exactly.
Okay.
So with allogeneic transplant, that graft versus host disease is a major risk factor for our transplants. There's also a longer period of time where the immune system is not fully functional after an allogeneic transplant compared to an autologous transplant.
So with allogeneic transplants, the problems in the past was the graft versus host, where the person's immune system doesn't recognize these new cells and blood coming in and attacks them. But I think, or you'll tell me, you've gotten to the point where you have better drugs that prevent that, and that allows you to do that more now?
Yes. Better drugs to prevent graft versus host disease, better drugs to treat it when it does happen. And also better manipulation of different donor types. And that's what has made the biggest difference in access to transplant for older adults in particular. It used to be that to be eligible for an allogeneic transplant, you had to have a sibling who was a match for you. And we match by something called human leukocyte antigen testing, HLA testing. I typically describe it to patients as like it's the answer key to your exam, and then we match people against that key, and we want it to match as closely as possible. Those proteins that we're matching on are the ones that we know are most predictive of graft versus host disease. So we try to match as many as possible to reduce the risk. But what we've learned in the last, a couple of decades, first we expanded to using more matched unrelated donors. And so Be the Match and other registry organizations.
A bigger pool of donors.
Exactly. And so you don't have to be related to someone to match them well enough to think we can lower the risk of graft versus host disease. So the addition of matched unrelated donors really expanded the pool for older adults, because now we've got 19 and 20-something-year-olds who may match at that important answer key spot for an older adult who may have only had siblings who are either deceased or have been diagnosed with a cancer themselves or some other condition that would make them ineligible to be a donor. There's also a growing body of literature that suggests that the age of the donor may be important. I'm not quite ready to say that's true across the board for all donors, but when we're thinking about a matched unrelated donor, younger is better than older.
So that's research that's ongoing.
Yes.
That you'll figure that out.
Yes.
Wow, so that's interesting. I hadn't thought about that as you extend the pool, younger donors who are possibly healthier, their whole immune systems, or everything is healthier.
They haven't aged because there's immune senescence. Just like other organ systems age, the immune system ages too.
Boy, aging presents a lot of problems.
And it depends on how fast you age. The rate's important.
Well, that's interesting because people age differently, and it depends on if you've ever been diagnosed with cancer. It depends on how well you take care of yourself. So kind of explain that there's your actual age, and then there's what, I don't even know the term, your actual age and your
physiologic age, biologic age. There are a few different terms. I would say physiologic age probably gets used the most. And as you can tell, there's not a clear definition of what that is. There's a classic diagram. And
physiological age is not your actual age.
Not chronologic age.
It's
but
the shape your body is in.
Yes. And so there's this graph that is chronologic age versus physiologic age, and it's not a linear relationship. Some people, based on genetics that they were born with, may age very well and may continue to look younger than their chronologic age. Some people may already be predisposed to age much more quickly than their chronologic age just with the genes they're born with. But then the lines diverge so much more as you get into your 40s, 50s, 60s based on environmental exposures. Some of that's how well have you taken care of yourself. Some of that's what have you been exposed to in your lifetime. I think when people get diagnosed with cancer, they often start to wonder about exposures. In Ohio, we get a lot of questions about pesticides, chemical exposures. Classically, we have situations like Agent Orange exposure for veterans who are exposed.
And now those the people that are exposed to burn pits in the military.
You get those events where you can see a clear link. And so some of those things are going to be related with accelerating aging.
Wow. So even if you keep yourself in really good physical shape, eat right, and exercise, if you have either a genetic issue or something you're exposed to, that can speed up your aging process. But then the opposite is true. People who have good genetics, who led healthy lives, could be chronologically 70, but physiologically 55 or 60.
Yes.
I hope I'm in that ballpark. Okay. We're going to take a quick break, and when we come back, we're going to dive more into the patients you treat and what's going on with older patients.
You didn't choose cancer, but you can choose where to treat it.
And when you choose the James at Ohio State,
you're picking a team of experts who understand there is no routine cancer.
You're opting for care from a highly specialized team dedicated to treating one type of cancer, yours.
A team that studies the unique makeup of your disease to develop a personalized treatment plan.
You're choosing our region's only comprehensive cancer center designated by the National Cancer Institute,
where more than 1,700 scientists are working on new treatments and new hope for every form of cancer.
At the James, you're making the choice to have the most advanced treatments, many of which were developed right here.
and you're choosing access to the James world-class clinical trials, dedicated support services, and an unmatched survivorship program to support your life after cancer treatment.
You didn't choose cancer, but the choice of where to treat it is clear.
We're back with Sarah Wall, and we're talking about BMTs for older patients. How did you get involved in this? Because this initially wasn't your specialty, but you grew into it as an area of interest because I'm assuming you were kind of passionate about this. So tell me about that.
Absolutely. So I did my fellowship training here at Ohio State in hematology and oncology. I started with a rotation on transplant service and fell in love with that. And about 2 months into my fellowship training, my grandmother, who's 92 at the time, was diagnosed with breast cancer.
Oh.
And so we've had at the James for, I will quote the year wrong if I try to quote it, but we've had for maybe 10 to 15 years, we've had the Breast Cancer and Aging Resiliency Clinic. And it wasn't always called that, but we've had a geriatrics focused clinic in breast cancer, was our initial focus there. And my grandmother was seen as a patient there. So I went with her to this appointment and I got to see how important geriatric assessment is firsthand. You know, she saw a physical therapist, a pharmacist. She saw a nurse practitioner who went through some additional measures of cognition and strength with her. She also was seen by a physical therapist. So she had this this very holistic, very thorough assessment at her first visit to try to figure out what would make the most sense for her as far as treatment options. So they weren't going to be dictated just based on what type of cancer she had, what markers it had, but also accounting for how she's aged and how healthy she was and what kind of geriatric conditions she had. And it was so amazing to think of how much thought went into that one patient care plan and how much she benefited from that. And so then as I went through training, Dr. Ashley Roscoe in our division of hematology had started building out a cancer and aging clinic in blood cancers in particular. And we've since expanded that to include all patients with cancer diagnoses can be seen in that clinic with us. And so I jumped in as a fellow and started evaluating patients who were being considered for transplant and then just carried that on when I finished my training.
Wow. And I'm a little hesitant to ask, but how's your grandma?
So, thank you. My grandmother passed away at the age of 95. She went to surgery, did very well with surgery, and then she went through radiation treatment as well. She elected not to receive chemotherapy based on some of her underlying frailties, and I think that was a very good decision for her. And she lived another 3 years after getting through that treatment. She rang the heck out of the bell when she finished her radiation treatment, and she died of unrelated causes with heart failure, progression of heart failure. But she loved that clinic. She very much enjoyed all the people she worked with there. Some of the people who she worked with still are there, and I get to work with them now on an operations basis, which is great.
And her legacy lives on in what
Yes.
you're doing
Absolutely.
now. So that's great. That's
Absolutely.
a great tribute to her. So give us a sense of what it was like before in terms of, I don't know if age cutoff is the right word, but
it definitely is.
Okay.
There's been an age cutoff.
And explain how you've changed that.
So generally speaking, not just at the James even, but in the transplant community as a whole, there have been chronologic age cutoffs, and they've continued to increase. There was a bar set as low as 40 years old when this was a brand new technology, and then it was 55, and then it was 60, 65, and now there's no official upper age cutoff for who is too old chronologically to receive an allogeneic transplant, or an autologous transplant for that matter. There are I think people have some soft numbers in mind about how old is the oldest person you would transplant, but it really comes down to an individual patient. And so one of the things that as a transplant community we have to continue to work on is working with the people who refer patients to us, because when many of them trained, there were these age cutoffs. And so when you trained, you might have learned that anybody over the age of 65 can't get a transplant, and they may not even get a referral to talk about the process.
Right. So you have to break that barrier.
Yeah.
And when you say referring physicians, it could be a smaller community hospital 100 miles away from here that doesn't have the facilities to treat someone. They send them here without even talking to that patient about the possibility of a transplant.
Right, and that's and it's not a reflection of the care. We get patients referred from all over Ohio and neighboring states, and they get excellent care. But sometimes that last step of whether transplant is an option doesn't get discussed based on chronologic age. If you look at national data for transplant, the percent of allogeneic transplants that were done for patients over the age of 70 was less than 1% if you go back a decade of total allogeneic transplants. But the percent of patients with a diagnosis that's allotransplant eligible who are over the age of 70 is much higher than that.
Because cancer tends to happen to older people.
It does. The median age of onset for most of these diseases is in your late 60s or early 70s. And so more recently, in the most recent update of national data, that number was up to just under 5% of all allo transplants are being done in people over the age of 70 or older.
Say you have a patient in their early 70s. What about their health, their physical abilities do you look for that would say, yes, you are eligible, you have a good shot?
So before, there is a scoring tool that's used that's it's called a comorbidity index, and it adds up points for diagnoses that someone has. And so previous diagnoses. And that's what is a little bit painful about it as somebody who specializes in working with older patients is the longer you live, the more diagnoses you accumulate. So one of the ones that's part of that scoring tool that comes up very frequently in older adults is if you've had a previous cancer. And so
that this is your second cancer.
This is your second cancer.
Oh, and you've been already treated with certain things.
And what's even worse is that sometimes people develop their blood cancer as a complication of the treatment of their first cancer. So radiation and chemotherapy exposure may have been a risk factor for them to develop the blood cancer that they're now talking about a transplant for. And then on the back end of that, we're going to say, but you already had a cancer, so this is higher risk for you. And so that is a tool that was built using retrospective data, so just collecting a very large number of cases and looking back at which things carried the most weight in terms of predicting who would do well with transplant. So it has its limitations in being retrospective. There have also been a lot of attempts to use age as a cutoff with that tool. The one that kind of stuck for a little while was if you were over the age of 40, you got an extra point against you for risk. And 40 seems really young. Like it's a slap in the face to most everybody we see. Well, you're over 40, so you're old. And so what we are trying to shift to is more of a fitness assessment, more of that physiologic age assessment. Yes, we still count comorbidities. Yes, if you've had previous chemotherapy or radiation exposure, you may have more toxicity with a transplant than someone who hasn't. But on a daily basis, are you completely independent in all of your activities of daily living? Are you doing an exercise program regularly? Do you have good cardiovascular fitness? We also look at, more broadly, we look at other things like your support system. What kind of caregiver do you have? Which is
true.
vitally important to getting through a transplant, that you have somebody who gets you through the transplant, who brings you to appointments, who helps with your meds. So that could be a whole other podcast just about caregivers for older adults, because
we have talked about caregivers are the unsung heroes of cancer treatment.
Absolutely.
Right? And particularly if you're old and living by yourself, that's not good.
It's hard to find a caregiver sometimes. And we've actually had to forego doing a transplant when we can't find an adequate caregiver plan. It's rare that it happens, but it is, increasingly as people get older and may be widowed or have children who, live further away, who aren't available, it can become a very major hardship.
Yeah, but I think that point you made, that you look at a person's physical attributes, that just one more reason that we should take care of ourselves, because as medicine advances and more of these options that like these kind of BMT transplants and that CAR T cell, that, if you're in good shape, you're going to respond better. So just another reason to eat well and exercise.
Absolutely.
Wow. So give me a sense of what would be the oldest patient you've done a transplant with? So
it's I don't want to jinx anything for her because it's very early on.
Knock on wood.
We're knocking on laminate that we have everywhere and around the James. No real wood to knock on. So she was 80 and 1 month at the time of her transplant. And very fit, had really taken very good care of herself, would probably have passed for physiologically being in her 60s, and so far, so good.
Yeah, that's a thing that you used to think of old as 65, like retired and you're old. 70, 80 people, even 90 people are still very, very physically active and running and cycling and rowing. And so you're kind of a pioneer in extending this age out. So 80 is your oldest.
80 is our oldest to date.
And I take it you have a lot of people in their 60s and 70s.
Yeah, we have for allogeneic transplants, 60 and over makes up a little over 40% of the total transplants that we do. So that I think I told 11% for 70 and over. So add another 30%, another third of our patients are coming in that 60 to 70 window. So it's a pretty significant number of the patients we do transplant for.
So for the older patients that you do the transplant, how are they doing maybe compared to people in their 40s, 50s, or even 60s?
So we just looked at this with a prospective study that I led through our Cancer and Aging Resiliency Clinic, the CARE Clinic. We evaluated 30 patients who were 60 or older who had a diagnosis that made them eligible for allogeneic transplant. And then we followed them over time. And about half of them went on to receive a transplant. The other half didn't proceed for various reasons. Some of them their own decision not to. Some of them their disease wasn't under good enough control. But of the patients who went through transplant on that study, the median age was about 70 years old, and the 1-year non-relapse mortality rate, so the rate of people dying of something related to the transplant, not their original cancer, that percentage was about 15%, which is about exactly in line with our whole program number of people dying from complications of transplant. And then the flip side of that, looking at overall survival, which is the more optimistic thing to talk about. Our optimistic our overall survival in that older cohort does not differ from the general population that we're transplanting here at the James.
So my last question, I always like to ask people what motivates them to do what they do. And you already sort of gave us a good hint with your grandmother and following through and wanting to give that kind of care to others. But maybe bigger picture, what's it like now that you've been doing this for a few years, when you get to see this 80-year-old woman and her family and others in their 70s that you have treated? What's that like when they come into your office after their transplant several months down the road and they're doing well and have a good quality of life?
So we've got, I've got a cohort of the first 3 gentlemen, 70 plus, that I transplanted. are all coming up to about their 5-year anniversary now, and they've had this running joke that they were going to take out a billboard with their faces on it and put my name on it. Please don't do that. But
I'm going to contact them. I like that idea.
So really, it's a testament to them and their family and caregiver support that they got through this. And we're the scaffolding to help them build that support on. But it takes, it takes a village. We say that all the time. It truly does. And it's very rewarding to be part of that. And especially to open doors for people that they thought were closed. I think also on a personal note, my parents are in this cohort. They're in this age group. And I tend to see my parents a lot in the patients that I work with. And so I think that remembering that these are people, this is not just somebody with a blood cancer diagnosis, and that's where doing these geriatric assessments allows you to get that, we call it that, the 40,000 foot view. It's not just how do we treat this cancer, but it's how do we treat you.
Wow. Well, thank you. Thanks for what you do, and thanks for filling us in.
Thanks for having me.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.